Thank you, Dr. Davison. I have a question first for the panel, and then I've got some individual questions, but I'll hold those individual questions and first take questions from the audience after this initial question to the panel. Several of you noted the importance of the life course approach that Dr. Taveras noted, and the need to really connect interventions across age levels and across settings. And I was wondering if you had any kind of recommendations as it related to how to connect across clinical community interventions, across age level interventions, and then how to systematize those efforts so they are sustained efforts and not one-time deals.
It's a tough question.
I can give some examples. This is more in some of our obesity prevention work we've done and obesity management work that we've done among older children is, you know, we as Ian mentioned, we begin our interventions in clinical settings and then we get out. And the way we get out is by using extenders of our clinicians in the form of community health workers, health coaches. We're also using quite a bit of social media and mobile technology to reach families outside of the clinical setting where, frankly, behavior change happens. It doesn't happen when they're seeing me or Ian in clinic. We're using video calls through iPhones. We're using text messaging. And I think we need to really be more creative about how to reach families in the settings, as we've all said, where they really spend much more of their time than our limited opportunities in clinic. So we've really maximally leveraged the ways to reach families outside of clinical settings and really starting to think of who can do that, because it's not going to be the clinicians in clinical settings.
To add to that, Elsie and I are both working on the kind of the core demonstration projects, which really has the objective of linking interventions across community sectors, including healthcare and community public health interventions. And definitely, you know, implementing concurrent interventions in all of these settings is a tremendous challenge that we undertook. And actually, the biggest challenge of all is making sure that the sectors are linked. And so lessons learned from all of that would be to have planning up front and having consistent messaging across the sectors and consistent materials that are used, rely heavily on media. We saw that when we interviewed stakeholders as to whether they knew of what was going on in other particular settings, some of them did, and it was through some of the media outlets that had been utilized throughout. Building strength in community coalitions and giving champions in each of the sectors opportunities, regular opportunities to connect with each other, because then they go back into their various sectors. So I see those as potentials going forward.
We have a question in the audience.
Yes, hi. Allison Steiber from the Academy of Nutrition and Dietetics. Dr. Paul, you mentioned Ken Resnickow's study where they did motivational interviewing, and I wonder if the panel could talk a little bit about the model, because the model was interesting in that the patient started with the clinician that was the PCP in a clinical setting, and then what was ideally supposed to happen is that the physician would do motivational interviewing for a few sessions and then pass that on to the dietitian that may or may not be in the clinical setting but could have been in an outpatient, more out community setting, and then they were supposed to follow up with 4 more motivational interviewing. And while the results were not particularly strong in terms of statistical significance, that third section is the one that got the largest change in BMI. And so I just wonder if that kind of multidisciplinary, multi-sectoral setting would be effective in cost and in pediatrician time and maybe quality of care.
Well, sure. As I mentioned, I think that there's only so much that can be done in the pediatric office, in my view. But supplementing it, as Elsie said, with other extenders may be a good model, and that the trial that I referred to that's worth partnering with communities. Again, giving the pediatricians a relatively defined role and then having it reinforced. One of the key things I think with a lot of the interventions that we talk about with our group is the dose of the intervention. And a couple of exposures to messages over a short period of time are unlikely to have a sustained effect. So a model such as the one you're describing from that study, where there's multiple exposures over a longer period of time, I think is probably more likely to have a sustained effect.
Another question?
Hi, my name is Stephanie Blake. I'm from USDA's National Institute of Food and Agriculture, and this is more of a comment. Dr. Ward, when you were presenting about the child care settings, you talked a little bit about how some of the child care providers may not be the best models for a variety of reasons. And I guess I just wanted to sort of encourage the idea you presented in terms of providing them the skills to teach those lessons, because the program that we run is a community-based intervention, and we use a peer education model. It's actually very effective. I think that as professionals, it's easy to say, you know, we know the information, we have the education, and we can provide it, but oftentimes it's those peer educators that can really relate and gain that rapport and that trust and really make a difference in the lives. So I just wanted to throw that out there as something to think about.
And Dr. Ward, maybe you could speak a little bit about what specifically you feel like might be some additional effective support and interventions for child care providers specifically as it relates to helping support their efforts to model behaviors.
Well, I think the ECE professional is really receptive to wellness promotion opportunities. In my early days of trying to do change at the child care setting level, and we're talking with the staff there about what they can do for nutrition and physical activity, and after a while they begin to say, well, what about me? Doesn't anybody care about, you know, my health and what, you know, what my needs are? So I think there's receptivity. We're also working at the facility level to look for no-cost, low-cost opportunities for health promotion at the facility where these people are working on a regular basis, so that they can have a social supportive environment and they can have reinforcements on their efforts to sort of improve their healthy nutrition and healthy physical activity. And there's probably some community opportunities as well to provide some service into the ECE setting by extension or some other professionals who might support wellness, worksite wellness.
Thank you, Dr. Ward. Dr. Barkin?
Hi, Sherry Barkin, Vanderbilt. Thank you very much for this really nice overview. And this question is really for all of you. You've been looking deeply into what works. Many of you have been leading what's working. And I'd like to hear your thoughts about how do we think about next steps? What would be ideal for message, messenger, dose, duration, and then how we amplify that so that we can improve health beyond one child at a time. So messenger, message, dose, duration, amplification.
All right, I'll try to. Okay, I'll try to tackle that one. Message. I think there doesn't have to be. There's not a single silver bullet here as far as the message. I think there's various messages, and in fact, one of the challenges may be that the message may, I think we heard a little bit about this earlier, the message may need to be different for different communities and different racial or ethnic groups based on the norms of their culture. So as someone who reviews grants, I think I see people making that justification all of the time that different groups need different messages. I think you probably have experience with that with your community. It's probably different than to some extent than the messages I deliver to the people in central Pennsylvania. The messenger, this is open for debate. I think that a lot of people, when there's a problem with child health, say, why aren't the pediatricians doing something about it? And I think I'm part of the answer, but I don't think I, as a pediatrician, am the sole answer. So it may take numerous stakeholders or repeated messages from different sectors of the environment to make that difference. So I'm not giving you firm answers on those first two. What are the third and the fourth ones?
Dose, duration.
Duration. So I think we heard today, and I would love to show that the optimal duration would begin preconception and continue across the life course. Mm-hmm. It's hard to get that in a 5-year grant cycle. I think we all are familiar with that. But I think that would be the duration. And the dose, I believe, needs to be high. Our studies, multiple home visits in the child's in the family environment, and the visits are 1 to 2 hours. Whether that is scalable is the question. So we may need to I brought up the centering care model, or others have tried group delivery models. That may be more scalable, but I think the dose needs to be high and repeated with boosters, since I'm a pediatrician.
If I could comment from the ECE perspective, I feel like that we should be creating a culture of health at the ECE setting, and so I think then dose is ongoing. So it's not short term, it's not an antibiotic. I think we need to elevate the quality of the experience as well as we can. I think the messenger may be in one way at the child care, the ECE professionals themselves, because they have this opportunity to communicate with the families, but it will take messengers who work and support the ECE folks, the child care professionals, the CACFP consultants, which is the food program consultants, or the licensing consultants, but we're not on board. We are not on board with this whole idea of optimal health for the children that we serve. So I think that the dose is, I think, the most important thing, but we need to have it as ongoing for the whole time that they're in those care facilities.
But Sherry, I also want to comment, I'm glad this came up. There's no communication between the different sectors, or there's very poor communication. The only time I ask about what's happening in child care, but the interaction between the primary care doctor and child care is only if I have to petition to get a child low-fat milk as opposed to the whole milk that they're mandated to give. Or the only time I ever hear from WIC is if a child's anemia screen turns out that the child's anemic. So WIC is giving messages that may be the same or different from what the parents are hearing from the pediatrician. And for a lot of families, that can be very confusing on who do I accept the information from? And it would seem that the different aspects of early child health would have some way to communicate with each other, but we don't.
And the last thing I was going to say to that point, Sherry, is that we're really missing opportunities to work within existing structures. So we keep, in a lot of our talks, we keep thinking, well, what's new? Well, what do we already have available to us that we are not working with? We're not working in WIC. There are none of the systems level interventions in pregnancy to 2 that have included WIC, and WIC is such a huge opportunity for children at high risk. We're not working on childhood obesity in home visiting curricula. We're not engaging fatherhood programs who are really actively looking for their role in early childhood development. And so I would also say that in order to have these sustainable effects that deliver a high dose and that can really get beyond the duration that we tend to have funding for, we have to work at a systems level, and we're really not doing that currently.
Let me ask one follow-up question, Dr. Taveras, then to you specifically as it related to your point about integrating obesity research with child development research. And that goes back to Dr. Barkin's question as it relates to messaging. One thing, and this is observational and somewhat blasphemous, but I've found in our work across areas that when the message is a message of health, it's the quickest way to get people not to listen. And so I didn't know if there was any recommendations you might have as it relates to messaging, also as it relates to more holistic child development than specifically obesity prevention or health specifically.
Right, so I think a lot of us are starting to see, thankfully, an investment in early childhood. We need to invest in early childhood. There's so much great evidence on neuroscience and toxic stress and early childhood experiences and their effects, not just in the short-term development of children, but long-term. But what I really would hate to see is that happens to the complete exclusion of taking that opportunity to also promote health and obesity or chronic disease prevention. And we're already starting to see that. And we already are starting to see that curricula that are really focused on promotion of development are really excluding or not taking advantage of the opportunity in this critical period to work on implementing or the beginnings of good nutrition, good physical activity, sleep, and how we think of these as, unfortunately, as two completely separate things. So another perfect example, maternal depression is probably the #1 adverse childhood experience that is experienced in pregnancy and the postpartum period. And that's one where even our own obesity colleagues, my own obesity colleagues, we're really thinking carefully about how to promote, how to screen for maternal depression, not just because we know of its effects on early childhood development, but because of its effects on improving or instituting good household routines and behaviors. But I think it's an opportunity, especially now with the investment and the reinvestment in early childhood development, to really do it well. And I should say that I say this to my colleagues in the departments of public health that I'm very familiar with, and they said, well, Elsie, the same thing happened when we shifted completely our focus from asthma to obesity. So now you know how I feel. And it's the truth. We tend to do this where it's the new epidemic and then leave behind problems that still exist and that are at historically high levels in our country and beyond. So I'd hope that we could really pay attention to the integration of those two rather than continuing the silos.
Bill?
Bill Dietz, George Washington University. So I have a comment in response to Sherry's question and then a question. I think that we need to spend much more time on the message, and Elsie and I were talking about this, about how one effectively counsels families to engage them in things like reducing sugar drink consumption. And I don't think we really have a systematic way of assessing, or we've not had a systematic assessment of just how to do that. But if we get the message right and specific, then I think the messenger is less important. Because what we need to do in terms of dose is make sure that that message is replicated across disciplines so that everybody that touches that child is echoing the same refrain. So my question is, how do you do that?
Well, some people are taking a health literacy approach to these things, making very simple messages using pictures, and I have found that approach to be I'm getting another question now. Because of that, but I'm going to go back to my clinician hat, though. And when I see families with a child who is overweight, there's not. It's for one family it might be sugar-sweetened beverages that's the problem. For another family, my child drinks water all day long. So it's hard to, there's so many different places that the problem is coming from. So no, my child never drinks soda, but they're having 4 Pop-Tarts every morning for breakfast. So it's hard to, again, there's not a one-size-fits-all intervention.
I agree. So that, let me try and refine the question a little more. So I don't, in a family in which sugar drink consumption is a problem, what's the most effective way of engaging that family around reducing sugar drinks? Is it dental caries? Do you need the family history for diabetes and the link to fructose? Those are the kinds of questions that I don't think we've been very good about answering, even in a qualitative way, so that we can begin to be much more specific about how we engage families and the need to change those behaviors.
So Bill, I don't pretend to know the answer, but I'll tell you who we've asked. It's parents and children. And we've done groups, we've done interviews, we've talked to parents to tell us what's the best way to motivate behavior change. We've invited children and asked children what are some ways to invite them to really give us feedback about how to get them to change the behavior. And what we are hearing is surprising, and this is even from, I guess I'm a veteran, I do have the white hair to prove it, a veteran in childhood obesity management, and I've heard things from children about what would motivate them that I never used to talk about. So to give you just an example of one of the children in our study, where we're doing this study of positive outliers of children with obesity who have managed to return to a healthy weight, they've told us that the things that motivate them are teasing, about social stigmatization, about peer relationships. They want to fit into the clothing that other children their age fit into. They don't want to shop for clothing at plus-size stores. They want to be able to swim with a shirt on so that their gynecomastia doesn't show. And it's really interesting, because I think that we sometimes fail to see that the answer to how to get families and children to change is actually by engaging those parents and children and helping us with the solution. So we're learning those answers, but it's through the engagement of parents and children that we're doing that.
Right, so this is a plea for a more systematic way of sharing that information.
Yeah.
I personally would like to see, major sort of leading public health organizations, IOM, AHA, line up with each other and basically, forget how we get to that point, but there's a set of messages that they all endorse and all say, these are the messages that should be used. And if we have multiple organizations really pushing that, I think we'll start to see those messages permeate consistently.
I think, too, in prevention work, that families need more than obesity prevention is the reason to do. And so we've done also talking to parents and talking to ECE professionals, because we're trying to link these two together. Parents don't want to be blamed, and they don't want to be singled out, so they don't want a message about their child and their specific condition, but they are receptive to being supported. Parents are trying. The vast majority of parents are trying and want the best for their children, and I think they're a bit conflicted about how to get there. But I think we need messages that relate to not having bullying, not having maybe having brain promotion that comes by having better quality of food, and the role of physical activity in building confidence. So I think we do need to ask what those messages are, but they're not always the ones that are being delivered by our core public health folks, which is just have smaller portion sizes. It's just not necessarily being well received.
On the prevention side, the one other thing as far as the message that we've tried to do is the stealth intervention. So every new parent wants their baby to sleep, and sleep as long as they can. myself included. So if we know that short sleep duration or poor sleep hygiene is a risk factor for childhood obesity and later obesity, if we focus on the thing that is desirable to parents, such as prolonging sleep duration, parents want that. So that's another way we can deliver a message that is going to be better received than talking about obesity prevention with a 2-month-old.
We've got 2 more questions, and we're getting short on time, so...
Thank you all for being here. I'm Whitney Leet from the ILSI Research Foundation. You all did great presentations on interventions that work in the childcare setting, and my question gets to those of us interested in developing sustainable and scalable interventions on using what doesn't work and where we can get that information, how we can use that information. And I guess that's a kind of political research question, but...
Well, we definitely know it doesn't work in early life, and at least in some of what I presented earlier, we know that interventions that only focus, for example, on a short period of time and didn't continue. So, for example, interventions that were only in pregnancy, when we looked at the pregnancy to 2, had no effect on childhood overweight or obesity. We know that there are some things that actually increase the risk of obesity, including protein supplementation in formulas. We don't tend to see a lot of null results published, and I think that limits our ability to generalize a lot on what doesn't work. And I don't know if you all would say the same. I think.
Yeah, I think we are limited by that. But so it's a publication bias, so we don't really know a lot. I think one of the things that in the ECE setting that is a sure ineffective approach is to try and have structured lessons for parents, who to come into the facility and be taught in a classroom kind of format. That's generally not a reasonable expectation. Families of young children are usually busy and have very engaged lives, and so we're going to have to get our information to them in different ways rather than having, say, traditional classroom kind of activities of engaging parents. And so I think that's one of the ways that we should avoid that approach.
We'll take our last question.
Okay, thanks.
Thank
Shariki Kumanyika, Roundtable member. I've been listening to this conversation and wondering about what it would be if the environment were different. So right now we're talking as if, given the onslaught of messaging about what parents should do or what it makes to be a good parent, giving your kids all the stuff that's not good for them and so forth, letting them stay up and have a tablet in the bed, in the crib, that all this is happening now, and we're trying to figure out interventions that can equip parents to overcome it. I actually don't think that's realistic or even fair to parents, because we'll never win. So the question is then, what messaging can be incorporated that gets parents to begin to push back, to push the demand curve the other way, that will ultimately change the environment, and then the dose won't have to be so high.
So one particular construct we went after in a pilot intervention we did was parent resource empowerment. And so the intervention really didn't focus on the traditional, diet and physical activity behaviors, but rather was going after things such as conflict resolution skills, media literacy, and in particular resource empowerment. And resource empowerment is the ability to identify the resources out there in the community that could benefit your family and then advocate for access to those particular resources. I think that's one example of how they can push back and explicitly seek out those things.
And for the sake of time, I'm going to bring the discussion to a close. I want to thank our panel for their presentations today. We are going to have a break. Lisa Loy from Bipartisan Policy Center is going to lead us in the final session of the day after our break. So once again, please take some time to get up, walk around outside the building, take a tour, see some of the art, and we will be back at 3:30 for our final session. So thank you so much.